Hi everyone, I am Dr. Akanksha Kashyap, Senior Lecturer, Department of Periodontology, BBDCODS, BBD University, Lucknow. So today we will be discussing about gingival curettage. So gingival curettage, it's the periodontal pocket reduction surgery without the use of periodontal flap, which is limited only to the gingiva, and it does not involve the underlying osseous structures. So curettage, what does curettage mean? Curettage means scraping something or scooping something out. So in this context, the curettage could be scraping of the gingival wall of a periodontal pocket to separate the diseased soft tissue. So now as we all can see, the periodontal pocket, it is lined by two surfaces. On one side there is tooth and the root, that is the hard surfaces, and on the other side there is gingival lining of the pocket or the gingival surface. So gingival curettage, it is the removal of the inflamed soft tissue lateral to the pocket wall. So this curettage, gingival curettage, it involves removal of this soft tissue which is lateral to the pocket wall. Now there is subgingival curettage. So when the scraping or the scraping procedure is performed apical to the epithelial attachment, severing the connective tissue attachment down to the osseous crest, it is known as subgingival curettage. Now, how does the curettage differ from scaling and root planing? Scaling and root planing, these are done on the hard surfaces, that is they are done on the tooth surface as well as on the root surface. So scaling, it is the removal of the debris from the tooth and the root surface, and root planing means the smoothing. It is a procedure which is carried out for the smoothing of the root surface so as to remove the remaining necrotic tooth material. And this curettage is performed on the gingival surface. So now there's another term which is known as inadvertent curettage. So inadvertent means something which is done unintentionally, which we do not want to do, but it is occurring and it is unavoidable. So whenever we do scaling and root planing, certain amount of curettage is done. So that curettage which is done along with scaling and root planing, which we do not intend to do, but it is occurring, that is known as inadvertent curettage. Now, what is the rationale behind curettage? So what is the purpose of carrying out the gingival curettage? Firstly, it is done for the removal of the granulation tissue. The granulation tissue, basically it is the connective tissue which contains the angioblast as well as the fibroblast. So this granulation tissue, it lines the soft tissue wall of the periodontal pocket. So this granulation tissue consists of areas of chronic inflammation, pieces of dislodged calculus and bacterial colonies, and it hinders the healing process. So this granulation tissue, it needs to be removed if healing is to be carried out. The second purpose of carrying out gingival curettage is elimination of the epithelial lining. So this granulation tissue, it is lined by the epithelium, and the projections, the epithelial projections, there are epithelial projections into the underlying connective tissue. So these epithelial projections are considered as a barrier for new attachment. They are considered as a barrier for the new attachment of the fibers. So whenever there is an attempt for the new attachment, gingival curettage could be carried out. So now there's a recent concept that the need for curettage only to eliminate the inflamed granulation tissue is questionable. For example, if there is a pathological condition, there's a periodontal pocket or there is periodontitis, and then a thorough scaling and root planing procedure is carried out. So this can lead to the germ-free environment. Basically, what is the cause of the inflammation? The cause of inflammation is the bacteria. So if we follow a thorough scaling and root planing, then the cause of the inflammation can be removed. So once the cause of the inflammation can be removed, the pathological process could come under the control, and then the inflammatory component could gradually resolve. So the remaining granulation tissue, it could resolve over a period of time. So hence, the need for the gingival curettage as a separate procedure, it is questionable. But it should not be confused with the elimination of the granulation tissue during the flap surgery. So whenever we perform a flap surgery, we need to remove the granulation tissue. So this granulation tissue which hinders the access, So this granulation tissue is removed for the technical reason. We want to remove this granulation tissue so as to gain access to the root surface or to the root morphology or the bone morphology. So this granulation tissue removal in the periodontal surgical procedures or the flap procedures, it is done for the technical reason, not for the biological reason. Now, curettage and aesthetics. The curettage procedure, it leads to certain amount of shrinkage. So when it is a major consideration when considering the areas which are aesthetically important. For example, anterior maxilla. So anterior maxilla, it's an area which is aesthetically very important and it requires preservation of the interdental papilla. So in these cases, in aesthetically concerned cases, when the surgery is not feasible and when it is difficult to carry out the reconstructive procedures, so in that cases, what we are going to consider is thorough subgingival root planing. So it should be done so as not to detach the connective tissue beneath the pocket. And in these cases, we should try and avoid curettage. So as already discussed, the granulation tissue in the lateral wall of the pocket, in an environment free of plaque and calculus, it becomes or it converts into the connective tissue, thereby the shrinkage is minimized. Now, what are the indications? There are very limited indications of gingival curettage. Some of them are when there are moderately deep intrabony pockets in accessible areas where a closed surgery was planned, but due to some technical reasons, the surgery could not be carried out. So in these cases, we can consider curettage. So hence the attempt at a new attachment is made. So in these cases, we can consider curettage. Also certain non-definitive procedures before pocket elimination by other methods. So if we want to carry out the pocket elimination procedures, so then before carrying out the proper procedure, we can consider gingival curettage. And when more aggressive procedures, they are contraindicated. For example, a long surgery or a reconstructive surgery is contraindicated in certain patients because of their age, because of their systemic component involvement, or because of certain psychological problem. So we can carry out gingival curettage in these cases. Also, it can be considered as a maintenance treatment for areas with recurrent inflammation and recurrent pocket. So despite the periodontal therapy, there are certain areas and specific person or specific people which have the tendency for recurrent inflammation and pocket depth. So in these cases, we can consider gingival curettage. So what is the procedure? It should always be remembered that curettage should be preceded by scaling and root planing. Because curettage in itself, it cannot remove the cause of the inflammation. It cannot remove the bacteria. So bacteria is the cause of the inflammation. So curettage cannot remove the cause of the inflammation. It just removes the gingival soft tissue wall of the gingival pocket, of the periodontal pocket, or the gingival wall of the periodontal pocket. So it should always be done after thorough scaling and root planing. The procedure involves the application of the local anesthetic in the particular area where the procedure is to be carried out. And then the instruments are selected, which could either be Gracie curette or universal curette. Then the cutting edge of the instrument, it should be adapted in the gingival wall. And then the instrument is inserted so as to engage the inner lining of the pocket. And the stroke which is used is horizontal stroke. And a single stroke is carried out along the soft tissue wall of the pocket, which is usually a horizontal stroke. Horizontally will be scraping the wall. Now subgingival curettage. In subgingival curettage, the tissue attached between the bottom of the pocket and the alveolar crest, this is removed with the scooping movement of the curette. So the entire tissue between the bottom of the pocket and the alveolar crest, that is removed, but the motion used here is scooping motion of the curette. So the area is then flushed and the debris is removed. The tissue is then partly adapted to the tooth by gentle finger pressure. Now there are certain other techniques for curettage, gingival curettage or subgingival curettage. One of them is excisional new attachment procedure, ENAP. Excisional means we are going to excise the gingiva. So it was developed and used by the US Naval Dental Corps in 1975. So it is a definitive subgingival surgical procedure which is performed with a knife. Coming on to the technique, after giving adequate anesthesia, the internal bevel incision is carried out. So the internal bevel incision is carried from the gingival margin, which is directed apically to a point below the base of the pocket. So then this incision, with this incision, we are going to excise this area. So this incision is carried interproximally on both facial as well as the lingual sides. So the intention is to cut the inner portion of the soft tissue wall of the pocket all around the tooth. So after the incision, the excised tissue is removed with a curette, and then the cementum is root plane. The exposed cementum, root planing is done. It should be important that we should preserve all the connective tissue fibers that remain attached to the root surface, and then the wound edges are approximated. So if the wound edges are not approximating properly, so then recontouring of the bone should be done until a good adaptation is achieved. Finally, the sutures are placed and a periodontal dressing is given. Now, there's another technique which is known as ultrasonic curettage. So as the name implies, it uses ultrasonic instruments like Morse-shaped scaler and rod-shaped ultrasonic scalers. So the ultrasonic vibration, what do? They disrupt the continuity of the tissue and they lift the epithelium, which results in a narrow band of necrotic tissue, which strips off the inner lining of the pocket. And then there are certain caustic drugs which can be carried out, which can be used to carry out the gingival curettage. For example, sodium sulfite, alkaline phosphatase, alkaline sodium hypochlorite, which is also known as antiformin, and phenol. So, but the use of these drugs is limited or completely obsolete because the extent of tissue destruction with these drugs cannot be controlled by us. Coming on to the healing process. So immediately after the gingival curettage, the blood clot, it fills the pocket areas. So after that, there is appearance of polymorphonuclear leukocytes in that area, which is further followed by rapid proliferation of the granulation tissue. And then there is maturation of the tissue with decrease in the blood vessels. So then restoration and epithelialization of the sulcus can be seen in 2 to 7 days. The restoration of the junctional epithelium usually takes around 5 days. And immature collagen fibers, they appear around 21 days. In 1989, Word Workshop in Clinical Periodontics, it concluded that curettage has no justifiable application during active therapy of chronic periodontitis. Also, a report by American Academy of Periodontology said that curettage is a procedure that provides historic interest in the evolution of periodontal therapy, but has no current clinical relevance in the treatment of chronic periodontitis. So as already discussed, the gingival curettage is a kind of procedure which is very limited. The use is questionable, but in certain cases where the use of where the periodontal surgical procedures, the lengthy periodontal surgical procedures are difficult to carry out, and the patient is not interested, or the condition of the patient is not feasible to carry out the long surgical procedure, and where the aim is new attachment gain. So in those cases, we can still consider gingival curettage. Thank you.